present your case and let us know what you are
doing.
doing.
So we have here a lady which we have to treat, and Dr. Galassi has come all the way from Catania in Italy. He didn't have a visa till 2 days ago, and he by now deserves an Indian passport. So he thought he didn't need a visa to come here. But all the same, I think Praveen managed a visa for him in 4 hours, and he's here.
But let me say something. First of all, that is a great pleasure for me to be here in a place where I was about 12 years ago, and also to work with Anil, Dhall, which have been working together probably 10 years ago, and also with Praveen Dhall, so all friends of us, of me, and it's a great pleasure for me to be here, and I'm really glad, despite all the issue with the visa, to be back again here. So let's present the case.
We have this 50-year-old lady who's diabetic, and she came with an acute coronary syndrome in March of 2017, at which stage she had some Qs and 3 AVF and some posterior basal mild hypokinesis with an ejection fraction of 45%. An angiogram done at that stage showed a left main which was normal, an LAD which had a proximal total occlusion, a circumflex which was long segment severe disease, and a tight disease in the ramus as well. And the RCA was totally occluded. So at that stage the syntax was 25 with an EGFR of 77, and in March of 2019 Praveen and his team have fixed the LAD, circumflex and ramus, and all that they have left for us to do is a total occlusion of the right, which you can see the angiogram. This is the angiogram which was done in March of 2019, and you can see that the right is totally occluded. It is filling distally. This is the right through some bridging collaterals, and the rest of the angiogram is basically the left system. So would you like to have a discussion, or would you like to see the angiogram that we have done just now? We have not yet started the case except for taking a couple of diagnostic shoots, and Ankit here has done that for us.
I think it's better if we just show what we did.
We show it. Stop the fluoro.
Okay, so we have now the projection from left, which is clearly showing that the LAD is well opposed, the stand is well opposed, also the circ, and there is a still good collateral flow to the right, and so giving us the possibility to work also in the retrograde fashion next. We can also have a very good understanding of the collaterals, which seems to be pretty nice. Next. From LAD. We have only these two pictures?
That's it. We've just taken 2 pictures.
All right. So basically the idea is, I don't know what is the idea from the panel, but our idea is probably to start with integrated approach and to try to see if by integrated approach we can solve the issue quickly.
Yeah. So we have a 7 French AL1, short AL1 with side holes on the right, and an EBU on the left. And here we are good to go once you tell us what your opinion is as to how you would like to approach the case.
You want to say, any panelists want to say something at this stage?
If not, then we have already a Corsair, and we are going to use some of the new Boston wires for the first time. So we have a fighter wire, which is like the Fielder XT, and which is right here. I'm going to give a little antigrade puff and see. Yeah.
This wire is very similar to the Fielder, and is so is a polymeric wire, probably a little bit softer, but also good handling and good movements. And we are trying to see if we can, as you can see, snickering inside the lesion. If not, we can try to see if there are other options. What I realized using this wire is that this wire is a little bit softer probably than usually Fielder XTR, but it's also very good for microchannels. This situation probably is not so clear if there is any channel or not, so this is something we have to test,
figure out.
Figure out. probably sometime I understand with this wire that a little bit of more push with the microcatheter, it's not so bad. And we have to see if we can find some way of going there. If not, we have to change our strategy and try to go with a stiffer wire, which may be Hornet. Hornet is also another wire that has been designed for CTO, similar to Conquest. Now it seems that the wires still have some good penetration. You see that with this polymeric wire you should work very, very softly, try to find a way, especially with this wire probably which is softer than the others. But you know, if does not bend the tip, this may be a good understanding. So that may be helped by the microcatheter. This is the reason why I choose Corsair, but any other microcatheter can go.
So we had a discussion among ourselves whether we should take a Corsair or a Fine Cross or a Caravelle, and well, we appear to have made good progress.
Yes, but we have to know if we are in the true room or not. Okay, we can make a shot. What do you think? Just to
Let me
understand.
just take a good retrograde.
I think he made a big
Yeah.
jump,
Yeah,
and he went through.
yeah,
This is my impression.
yeah.
Okay,
So,
go.
Cine.
Yes. So as you can see, this wire basic work like a filter.
Yep.
And we were a little bit in doubt at the beginning because it was a little bit curving at the tip, but then maneuvering with small...
Also, by now we know how a fielder XT responds,
Exactly.
and we were not very sure as to how this wire would respond.
Exactly.
So, if we can focus on the hands to see how.
But you see,
great.
it is interesting that you should never desist, and you should always persist. And now that we have been having so many years training with the Asai wires, we know that also other wires may work similarly.
Similarly.
Because now our hands know how to handle this wire.
Now even
I
Asahi
think
has got some new wires.
I
that-
think that this is very interesting for us, and also for the audience, and also for the other companies that are working and are giving us new support. Now we change
Samurai.
this wire, which is a polymeric wire, with a wire which is called Samurai from Boston again. It's a wire that is
Which
very
is
similar to Sion.
Sion.
So it's a very spring soft wire that can be used exactly as Sion. I tried several in several cases for retrograde approach. I must admit that it's very nice.
Yes, please.
We cannot hear the comment.
Heard the comment. Want a trapper?
This is Dr. Alfredo, Dr. Werner say that this is a stiffer wire than the XT and the XTR. Am I right? It is 1.5.
You mean the fighter?
Yeah.
Well, this is in principle, but in practice, since I've been using this wire, I realize that it's totally different. So this is what I'm usually experienced, that sometimes the theory from the practice is totally different.
I have never done it
This is
like
what.
Yeah, so it's a trapping wire. This is their technique. They keep the hard end of the wire so as to keep it from going inside. I have never used it like that. It's okay.
It's okay. You just push it inside for a few.
Okay, don't please don't.
No.
make me-
We are not.
We'll
We'll remove this after you got inside the two heat. It's only to get through the two heat.
Okay.
So let's go to the Bombay
Okay, no,
again.
we are using a trapping balloon from Boston.
No, no.
So while they
So
cross
this balloon
this
is
with
from
the,
Oxford.
From Oxford.
let's go to Dr.
They are
Basu.
trying with me to do all the new
Okay,
strategies.
now we can remove this.
Aspetta, wait. They are trying with me to start with the new stuff. Now I understand, because it's soft.
Dr.
Now I
Dhall,
understand.
we are going back to Bombay.
Yes.
All right.
While you do some work here,
Yeah.
No, okay,
let's
we are
listen
just
to the
doing
Bombay guys, what they're
okay.
doing at
They've
this
just
time.
gone
All right. So basically, as we said, we exchange the wire, the fighter, which according to my experience looks much softer. I don't know what is the impression of Dr. Werner, but I think for me it's much softer than Fielder XTR. And we changed this wire with a samurai wire from Boston.
Yeah,
Yes.
we started the pullback.
Yes. Yes. You can start.
Yeah, we've
You
started.
can start. And then we change with samurai, which is basically similar to Sion wire, spring with hydrophilic coating and distal part, very soft. Then we dilated with balloon 2.5, the lesion. And now we are making the IBUS examination, mainly for the distal part of the artery, which seems to be having some stenosis, but we don't want to treat this stenosis.
No.
This is our impression, but of course we will discuss with you. And then the proximal lesion, in order mainly to understand if we were central to the plaque or we were subintimal, although of course this doesn't, at the end, clinical is not relevant because we will implant the stent depending on the size of the vessel, and that's it. If you can see now the IBUS, can you see the
Can
image?
you focus on the iris? Yeah, already. All right.
Okay. If you see the IMUS images, we are approaching the area of the occlusion, which is the proximal area. There is some plaque burden, but not really
It's
major.
fibrotic. Yeah.
It's fibrotic, but not major
We can-
calcification.
So the size of the vessel is?
The size of the vessel is about
3.5.
3.5. Now we are approaching the place where the lesion was basically occluded. I'm keeping on the fluoro in order to understand also the progression of the IBUS. You are both on the screen now. No much calcification. The wire is centrally into the core of the architecture of the vessel, and it is very interesting. And it's also very interesting because we had some fighting at the beginning, and we thought that it was basically probably going around the plaque, and instead, as you can see, seems to be very nice. And this is the ostium.
It's a completely intimal progression.
Intimal progression, so very nice progression, very nice success from this wire. So at this stage we have 3.5, so I think we have now, depending on we can make some nitro for the distal part of the vessel.
Yeah.
Okay, we remove the IBUS. We have some discussion about the distal part of the artery. Can we show the picture, the angiographic picture, please, while we are doing some nitro? So after the dilatation of the proximal area.
So you all have seen the IVUS as well, and it's our opinion that we should only treat the proximal, but we are completely open to suggestion from your side.
Okay,
We're just giving a little
this
nitro.
is the picture. There seems to be, from the angiographic appearance, there is no a plaque at all, but we want to see also after nitro, how does it look like, even because, as we know, these lesions, generally speaking, in the clinical area, in the clinical arena, we never use IVUS for these lesions.
Yeah, that's true.
So we should do something that sometimes is not out of the world. Otherwise, when we work then in the real practice, in the real world, in the real clinical setting, then it comes totally
Can
different.
I just see the
Yes. So we made some nitro. No.
Yeah, we've
You
given
made
some nitro.
I
Yeah,
will
one.
make some more.
We'll make a picture.
We make a picture. We can review the images, distal lesion. Okay. From the angiographic image, it seems to be that we need a stent.
Yeah.
Can we have an epicranial projection? And also, I would like to review the
We'll
IVUS
review the IVUS. Yeah.
in the more distal part. Okay, let's make another picture here, Anil.
Yeah.
Okay, go.
That point
Yes.
just before the bifurcation.
It seems to be that actually the artery enlarged significantly as compared to before. And probably now is the time to put the wire into the PD.
PD,
Hmm?
yeah.
Do you agree?
Yep.
So
So-
we can take this wire and put the wire in the PD, and also at the same time to have a look of the IVUS and discuss with the audience what to do.
You want to take another wire, or you want to take the same wire into the PD? You can take another wire.
We can take another wire.
You
yes,
can take
okay.
another wire.
Give
So
me, no, give me the same samurai, the
Samurai.
same fighter, the same fighter you gave me. Oh, no,
No, no,
samurai,
samurai,
the new
samurai, no.
samurai.
We have another samurai? Yeah. You want to use a crusade just to demonstrate?
Yes, well, that
Okay.
would be great.
Yeah, so give a crusade.
Well, in this situation, of course, not really this situation, but when you are thinking that your wire is in subintimal
Yeah, yeah,
space, the ideal would be
And
to
also
use
get
a
a
dual
crusade.
lumen catheter, because using a dual lumen catheter, you are sure that you are using the same channel of the previous wire. And this allows you to do the best work.
Yeah. No,
And-
first, let's
yes.
get the crusade first.
And this is the idea of getting a dual lumen catheter, because sometimes you might go with a new wire in some subintimal space, especially because when you have very calcified and plaque rupture, this is quite common, and this is totally very safe with the dual lumen catheter. Dual lumen catheter nowadays in the EuroCTO club is used about almost 11% of the cases.
Hmm?
And it's very interesting because more and more the operators are using also dual lumen catheter
So
for
we-
antegrade.
Yeah, because the penetration
parallel
force
wire
increases
technique.
and
Yes.
the parallel wiring becomes much
Yes.
more controlled, side branch access can be retained, although the most dramatic thing is to have a swan wire entry into an angulated side branch, but we don't have to do all those fancy things here. Yeah.
Okay, as you can see, the marker, there are two markers in this microcatheter. One is the distal marker, and the other one is the marker of the other entry point, of the OTW entry point. So we are using again the samurai wire to selectively going into the PD. But I would like also to see the IVUS, because
Yeah.
we thought that the IVUS, we did not really pay attention to the IVUS
We can repeat an
for the
IVUS.
lesion.
And we can also
thought
see the
that this lesion was not so
osteoproximal PD.
important. So generally speaking, I think we should make some gentle injection, just to understand our position in comparison to the crux of the vessel. Please make a short, just a small test. Try. Probably
Dr. Anil, what is our plan now? Are we planning a dedicated bifurcation in this
Can you
case?
No.
focus, please?
We'll just get the wire into the PD, and then we'll decide we'll assess the PD ostium and the distal right, and then we'll decide whether we need to firstly treat that area, and if we need to make a dedicated this is a second branch.
It's not
This
a
is,
PD?
it's not the same branch.
No, it's PD.
No, PD is proximal.
You are right. I thought it was much
Yeah.
more distal.
You want to talk?
Okay, so we go into. Okay, we try to give.
Yes. This is
Okay, so as you can see, also this wire, it is very nice because it can bend, and this give you more secure. Okay, we do the same issue
Yeah, we
with
save the same trapping. So we have the same Dr. Goel technique of using. So these are all hacks, and every institute has their own hacks, and Dr. Goel has devised a hack here of getting an Oxford balloon, which he's using as a trapping balloon, through the Tuhi post. You're having difficulty.
Okay, remove this wire.
Yeah.
Okay, so we will do the trapping at the distal part. We remove the dual lumen catheter, and now we decide after a little bit of action of the nitro if we need really to implant the.
We go more distal. Yeah, or pull the.
Okay.
Okay.
Okay, and inflate. Okay, so now we remove the dual lumen catheter. Usually when I do this, I always have a trick that I bend the wire
Yeah. So you
in
can
order,
see that
in
he's
order
bent
to
it.
make sure that
So he
which is which, and we don't have any trouble. Because to put the,
Flora, I just
unfortunately, the
wanna see it.
introducer is not a big issue. It's
All
not
right,
a big
all right.
knife. Okay, you can remove now the balloon.
Can you get
Okay,
some nitro?
we make nitro a lot or small. I think very little nitro we
Little
make.
nitro.
I think we need more nitro, because I think this lady has a very resistant nitro to the plaque there. But probably, I would like to also, can you assess the distal part of the you make the assessment of the IVUS? Because it's, I think it's very important. Once we have the IVUS. Okay?
We can actually get this out. We can get the guide out. Not required.
Okay. So focus a little bit on the, okay, well done.
One sec.
Ready?
Yeah, one sec. Let me get some contrast. All right.
Well, it seems to be that we need a stent.
Yeah, but we can do an IVUS.
We can do again the IVUS
We
if
can
you
do an
like.
IVUS. Yeah, yeah.
But we did already the IVUS. The
No, we
previous
can
IVUS.
just also see the size of the PD ostium.
You don't want to dilate the distal area,
I think
Dr. Dhall?
I think IVUS probe will go. If we find resistance, then we will dilate.
Yes, once we have the luxury to have IVUS, this will be done. But as you know, most of the time you don't have this luxury. Not here, not in any place. Even in Italy, we don't have this luxury to have IVUS available
Yeah.
for every case. And usually we rely our eyes to the angiographic.
It's good to hear that because a little ahead.
Okay.
Yeah.
So this is also important because we can also assess the PD lesion, if
Yeah.
there is any,
Right.
because I think more relevant for me is the PD lesion
That's correct.
than everything
A little
else.
ahead.
Okay, so we can start now
A
with
little ahead,
I
little
can
ahead,
go a
little
little
ahead,
bit
a little
more
more.
distally,
Little more. One second.
and then,
All
okay.
right. All right.
Imaging on.
Imaging on. You started.
Okay.
Yeah, please.
So this is PD. Please put it on the screen there.
Yeah.
And PD, as you can see, is totally free of lesion of stenosis. This is a 2.5, even more.
2.5.
We are approaching the PL branch. Did you start?
Yeah.
Okay, I'm keeping the image, and it's totally free of lesion, the PD.
That's
Now,
correct. Now
apparently,
this is the ostium.
now this is a plaque. Here there is a plaque. There is a plaque at the ostium of the branch, as you
Can
can
you
see
bookmark
there.
that? Yeah.
And indeed, it seems to be that there is quite stenosis.
Yeah,
Now
this
we
is-
can understand that the stenosis is there. It is clear that there is
Yeah.
stenosis. And probably we should, yes, it is clear.
yeah.
Now, it's very clear there is quite a strong plaque,
Significant plaque. sorry.
significant plaque, so we have to treat vessel, and the vessel is about 2.5, even
2.5.
2.5, 2.75. So I think we should implant a distal stent, plus a proximal stent of 3.5.
That's correct.
Okay? Is everybody happy with this strategy? Also there, if the lesion is still
What
going.
about the panelists, what they want to do?
Can just
Please
see
tell.
we can.
So can you just tell the final plan, like we are planning a stent RCA to PDA?
Yes, we are
Yes.
setting RCA to PD and keeping the wire jailed, just in case we want to re-wiring the PL, but our idea is only to put a stent, and then probably to leave the space in between, which seems to be okay, and then to treat the proximal area with a 3.5 stent. Okay? So if you want to move to the other room, you can move.
I think they've already done the other case, so.
So if you want to follow us, it would be a
You're
pleasure.
good.
And as you can see, the mid part of the lesion is totally free of lesion. So, and then we reach the area, is still going?
No, we can resume. We can.
I think if we are talking
Okay,
physiologically,
okay.
it
All
should
right,
not be
let's move.
stented if IFR is negative.
Okay, let's
But
remove it.
here the problem is,
Yes?
but here the issue is there is no distal landing zone as such. Where will you land the stent?
Do you have missing physiology? on
Because
this? You
the
don't have.
disease in RCA is right till crux,
No,
and it is
physiology,
extending
physiology.
beyond the crux into PDA. That is why they are planning a stent RCA to PDA.
Yes, yes. This is for sure. Once we put a stent, it should be in PD, no?
Yeah.
Because we understood from the IOS, it was like that. Okay, so let's select the stent.
So we're going to use what a Promocelite,
Yes.
which is the stent. So what is the? Can we see the first bookmark from the first bookmark?
At least 30, no? 28, 30.
32.
If we
In the
want
meantime,
to,
can you just show us the final run after doing the balloon?
Yeah.
Some discussion is going on over here about the strategy of stenting in this case. Can you just show
I don't think we
the
need to.
final run,
This is gone.
angiography
Yes.
run?
yes, of course we can show the final run. The final run shows that the plaque is involving the circ, the posterolateral branch. So we want to stent the origin of PD.
That's correct.
This is for sure.
The simultaneous angiographic run.
Simultaneous angiographic run. We have actually
No,
removed
simultaneography we
the
remove it.
removed the
We
left
can't- we
guide
can't
because
make it.
once we got across,
No, the recorded run.
you want us to go back on the recorded
On
run.
the recorder run, we
You
can
can
show
go back.
you.
On the, no, he wants the angiographic run.
If you
Angiographic run.
give me a
You can-
balloon, I will
yeah.
try to check the length.
Okay, you can give
Give
a,
me a
you have a 30,
25
30,
or
30,
20.
28 balloon, O balloon,
No, 28 balloon. 20 balloon we have. 20.
O balloons.
Okay.
You have stent balloons?
Over the balloon.
Stent balloons you have?
Balloons no. We
Just
throw
for,
it.
you
Okay,
throw it.
20, but 20. We
20,
pre-delay. We pre-delay.
We pre-delay.
220.
2.5.
No, 2.5, 20. Okay, can you see the run?
Yeah, we can see that.
So it is clear that the lesion starts more distally to the PL origin,
One side.
and we need to stent,
तो मैं तभी तो बोल रहा था।
and we need to stent the origin of PL.
थोड़ी ना करना.
नहीं उसको inflate करना।
Before stenting the into the PD, wouldn't you like to balloon the
Yes, yes.
Yeah, we're
ostium,
just, we're
ostium
just
of the
doing
PLV?
that.
Yes,
We're just
yes,
doing
yes.
that.
We are,
Now,
we are
ostium of the
predilating
PLV.
the lesion, but we don't want to make so much predilatation because we don't want to affect the ostium of PL. So this is just...
In any case, even if that plaque which you're seeing is going to be less than 5 millimeters from the ostium, so even by all the European Bifurcation Club recommendations, one should not predilate it
No.
at this stage.
No, I agree also because the PD is more important than PL in this patient, and also because we should accept some minor stenosis. Okay, so this is now the balloon to predilate. This is, okay, you can predilate here, gently, very gently. This is 20, so I think we should, with 28, I think
28,
is
yeah.
more than enough.
Yeah,
Do you agree?
yeah.
28 by
0.5.
2.5
5 or 275?
Even 275, I would say. Because 275, the vessel maybe.
All right.
Okay. The plate. This is a 2.5 balloon.
So this was 2520 balloon.
Yes,
That's
this was
correct.
2520. So we want now to, according to the size by the IVUS, I think the 275 might have been okay, or 25 with some expansion. or
2.5,
expansion.
just
What
show
do you
the
think?
first bookmark. Yeah.
You can also do 25 and then we can over
Wait,
expand a little
there's
bit more.
2.5 also, that's good. Just show the first bookmark. Yeah, just show the,
But look at that. The lesion opened very nicely.
yeah,
So I think that because we
yeah, 2.5.
2.5, well,
Yeah.
2.5 by at least, I would say 28 or 30. I don't know,
But
because I
30
want to
we
reach
can
this
either get-
area. I want
since
to
we're
reach
using-
this area.
Yeah,
Well, we can then at the end we say that we can also treat the whole vessel up to the crux. I don't know.
yeah. So 275 is also okay because we can,
Also 275.
Yeah,
Although if it's
275,
275, I prefer 275. According to
275,
my
28,
eye,
yeah, Promus Elite.
is
So this is the
275.
new laser cut hypotube with very good deliverability. So actually we were not wanting to pre-dilate because we wanted to test whether it actually delivers across that lesion. Yeah, 275.
So now the problem is, Anil, is only the issue of the if to stand all the way through or to leave a place.
No, I think we'll follow the criteria of
Of the
50% plaque burden to 50% plaque burden.
Okay, so we
So,
should
so
not
we
treat.
should not be in a hurry to create a FMJ or a full metal jacket. And
Yes, I fully agree, even because the IVUS tells us that there is a space
there
free
is
of
there is a
lesion.
large space which is free of
The
disease.
patient is also diabetic, so less stent we implant, the better it is. So we have the stent is a Promus, no?
Yeah, this is a Promus Elite. This is the new iteration of the Promus stent, which has got better deliverability, we are told. So it's the first time I'm using one. A new.
Okay, so theoretically the position is nice. We can say that we can, okay, we can go a little bit
push, yeah.
down.
Yeah,
Huh?
send.
Okay, and then we can implant. Okay, I think it's okay. Hmm?
It's okay? Okay?
Okay, you can implant.
All right.
We gel the wire.
Yeah, so I'm going up 10. 11.
Nominal is,
Nominal? 11. So I'm at 11.
okay, you can go up to 12 also.
Yeah, that's
All right, perfect,
so,
okay. Okay, so we can
okay,
make a
the
picture.
Looks very good.
We can also see in a different projection. Shall we go, Elio? I don't think there is any need to pre-dilate,
No, no.
to post-dilate the branch, but please, let's make another picture. No?
No, I don't think so. We're quite good.
Do you
We'll see
agree?
that after the final IVUS run. We can just
Okay.
fix the proximal lesion.
Okay, let's fix the proximal lesion, but we have to remove the branch now, the wire from the branch, because we don't need that at this level anymore. In case we can always
You have to take the one which is with the bend.
Yeah, the one with the bend. This is a good solution. Okay, we can do some nitro at the end. Then,
Yeah.
if we need, we can post delete afterwards.
That's correct.
Okay, so now we stent the proximal area with 3/5 stent, and the length should be, I think, approximately the same. No,
Is that, will that be too long?
too long.
Let's just see the angio
I think we should go from the branch.
from the branch.
From the branch
Yeah,
to the
28 should
ostium.
be okay.
28. Okay.
But we'll have that little area where there will be a plaque.
yes.
So we are going to
We
actually
should go
end.
to the ostium.
Yeah, so we will, 28 is fine because we'll have to come to the
Mm,
ostium.
mm.
So 3/5/28 Promus Elite.
Okay.
We are cognizant of the fact that we may actually, it may not look very pretty because the middle portion does have a plaque.
The mid portion will be with some lesion
Will
left.
be having some lesions.
But this is our strategy, not to implant the whole stent.
Yeah, we
Do
don't
you
want,
agree?
we don't want to create a full metal jacket if we can avoid it.
Is everybody okay with this strategy, or somebody else is suggesting different approach to stand the whole way through? Because sometimes it's
I
also
will stand all the way.
You'll
the
stand
way.
all the way?
Yeah, because there is a plaque just proximal to the stent, and I really don't think that there is any great purpose of leaving some vessel.
we
in
will
between.
leave small pieces, not coated.
Yeah, it is going to be very
Give
small
me,
piece.
give me
anyway.
give me the previous balloon. One
Give
minute.
me
Give me the
one
previous
second.
balloon, the balloon of the stand.
The stand
I
balloon.
want to check the length.
Stand balloon, Abhi, you threw it.
Well, me too.
Okay,
At
they'll
this
give the
stage,
20 balloon.
for 10, 15, 12 millimeter, probably I would stand the whole way through, and that's
So the
it.
stand balloon they have discarded. We can take the 20 millimeter balloon.
20.
Anybody from the panel?
But if
I
everybody
would
is
stand right. I would
the whole way.
stand right, cover up totally.
Even because at the end
Full
we
metal
will
jacket.
we will feel sorry for not
What is
having.
the audience poll? Anyone from the audience? Would you like to leave some part
Despite the
or
fact
stand
that
it
I
all
also
over?
showed us that there is a small part of the artery which is free of lesion. I agree that probably. Okay, so we
Okay,
have
we have to come
here
back
we
to the
have a
osteo.
20
Yeah.
plus another 20. Yes, because we have to get out the from here to here. So this is the. Can you inject this? We are at the ostium now. It's okay. Okay.
Maybe you need
Then,
48.
No, don't need to do anything. Just fluoro, and then another more than 20.
Yeah.
So
it'll-
probably 40 is
48
not enough.
if you have-
48. We need 48.
3.5, 48.
3.5, 48.
So the panel managed to convince Alfredo to actually make
No,
a full
I
metal.
was a little bit more convinced than you, but then at the end I'm always
Open to suggestion.
Open to suggestion. I think that I agree.
Makes sense.
That makes sense.
So,
yes.
Dr. Galassi,
Yes.
your comments on your choice of the stent in this case?
Sorry,
Inconvenient.
Dan?
We'll have to take. We'll have to.
The size.
No, the make of stent, the choice of stent.
The choice is a
48.
Promos. 48 Promos.
No, we don't
three-
have a 48. Promos doesn't come in 48. So
Ah.
we'll then. It's okay. We can take a Zan's Expedition. Zan's Expedition
That's
48.
Expedition 48.
Yeah, because
48, you don't have many choices.
that's correct. But Zan's Expedition is basically the same. Yeah, same drug, same everything except little less platinum in the alloy.
The distal stent, I would have preferred Onyx actually.
With
at
48, there is going to be
bifurcation.
too much overlap between the metals. So
No, I'm saying distal stent, they have put
No.
the Promise Elite. It's okay, but I would have preferred Onyx because of the
Any specific reason for that?
side branches. Side branch occlusion is very rare with the Onyx.
So the characteristics between these stents are not very, very different. But
Right
anyway,
there, yeah.
So I
that is
No,
what
no,
I
no
was
no it's
telling.
not too
Not
long.
long at all.
The guide is
perfect.
inside. So we'll
It's
just
perfect.
we'll have to
Make a picture.
yeah. One sec. Let me just
Okay,
yeah.
so we are at the ostium and we are exactly at the side of the
Yeah.
lesion. We can check a little bit more.
I normally go one mag up. Yeah.
Okay, just to make sure that. Okay. we have-
Okay.
I think we have to go 1
One
millimeter
mean
inside.
push.
Yes.
Yeah, we had need
Yeah,
to
the
push it.
length is really very perfect, but is really perfect. But we have
Yeah.
to make sure that we don't
Yeah.
make a mistake, because if we miss,
This looks okay now.
it looks okay now. Okay, okay, you can go now. You can implant.
All right.
But this is the reason why I always prefer to measure by
What's up?
by the stent, by the balloon, because with the balloon you are always sure that you are doing the
Even
good
in
job.
India, we'll by and large, most of the labs which still
So
use a lot
here-
of Oxford balloons.
So here it seems that there is too much of overhang of the stent into the aorta.
Yeah.
No. The deflate? No, it's perfect. Because this is plus left, you can deflate. And of course, with the plus left, we were deeply engaged into the artery. Now the balloon of this balloon of this stent is very good, but the balloon is really not so fantastic. So I don't want to lose.
You'll get an LSD at this rate,
Yes,
even if
I
it
don't
is.
want to destroy the ostium. So what I would like to do is I would like to do use another stent for the ostium and for the overlap. So give me a 3-5 non-compliant balloon.
So Dr. Alfredo, what kind of restenosis you would expect in this patient?
Similar to the left system.
Yeah, that's fine.
And because the left system, I hope, is okay, I hope also the right will be okay. But of course, this patient should be followed, and because he's diabetic, and so this is our major concern. Remember, the 25 syntax score was the syntax score before the
Before.
full treatment.
So what we had was the syntax was less than 10, I guess.
So we need to open up a little bit better the ostium.
Let's get a little light. My vision. Just do this one.
And then we do some nitro again, because the pressure goes up every 10 minutes. So it's good for us. We can give nitro nicely.
I think ultimately newer improved version of bioabsorbable stent may be the solution to these problems.
Well, the newer
hopefully-
absorbable stent, the magnesium one, are very nice.
So what has been your experience with implanting McMaris in long CTOs?
Well, I don't have experience of this kind of. Okay. First of all, we do the overlapping here. This is 3-5, no?
Yeah.
Okay. And now we do the ostium. Aspetta, wait a minute.
Okay.
1 minute, I want to get out. Okay.
Oops.
Okay, no
Oops.
problem. Because the guiding is deeply inside the artery, and so of course it's not so good for this lesion, because we are at the ostium exactly.
It
at the
seems it
ostium.
will be better if we can change
Now
the
we can
guiding
change
to
it to
simple
a
Judkins
Judkin.
at this.
Maybe
maybe
that
we're
is- maybe it's
okay.
enough. Let me
Good.
see. Yeah, because we are exactly at the ostium of the artery. Probably Judkins would be better. Let me see if I can.
This is you're in the LV.
Maybe in expert hands it looks fine, but what is your advice for the other people? Like in this case, if somebody is not very expert,
No, I mean,
shouldn't he change this guiding to simple JR right now?
Yeah,
Yes.
we also may.
No,
So-
also because the wire is destroyed. So we need to do this because the wire is unfortunately not so good, and we cannot handle the. Okay, let's take Judkins. I don't want to destroy the ostium
Yeah,
of
yeah.
this
You can even give a, no, you
and
can give a
also I
fire,
think
6
we
French.
need,
6 French is
also we
enough.
need the other samurai, because we
This
had
one is
two
destroyed.
samurai. This is samurai is totally destroyed. The other one is better.
Dr. Alfredo, you have 4.5 minutes total.
No, we'll show you, and
We'll
we'll also
show
do
you.
an IVUS run.
Okay, give me the catheter,
Judkin,
the wire, 30 wire.
Judkin, it's a 3.5. Oh, lady, hai na? Yeah. Just go down.
It is a little stiffer than the XT. It's more stiffer than the XT.
It'll bleed, your.
Okay, give me the wire.
Have you engaged? No. Let's see.
No, I'm okay. Give me the wire. It's okay. Give me the wire. No, it's okay.
No.
It's okay. It's okay.
That's the only problem about putting stents in the ostium of the right coronary artery. God
no.
forbid if somebody has to come back to do a primary, sometimes it can be very difficult.
I'm sure it is a little bit solace to the people who are beginning in their career that even experts can lose guiders in the end.
There's too much stent struts into the sinus, I suppose.
Right.
That is going to create even more problem.
So for interventional cardiology, you should have 0 stress levels, you know. You can't work with stress.
No, you're not there.
Why don't you give a shoot at least to tell us where we are? Just a little bit die.
Yeah, once we engage, we will.
Because I don't think you are aligned to the...
Yeah. So Alfredo is just finding that as gently as he can. No, you're not.
Okay. Now probably. Give me the torque, please.
No, it's not there.
Test now.
Yeah, that looks better. No.
I think the problem may be that maybe 1 or 1.5 strut is outside the ostium, and getting into the
That's
vessel where you have stented the ostium is always
You want
a
to take a balloon or take an
issue.
IVUS straight away?
No, first the balloon. I want to see if the balloon get across.
Okay.
Yes, maybe that we are
Through one
across the some strut. But we will see by the balloon, because if the balloon will go across, it's a sign that it's going. It's not. If
No, I
not,
think the smooth passage of the balloon will be the best test to guide us that the wires
But
no
we've all
through the
learned that it
struts.
is not always a perfect test.
a new balloon can cross easily.
No, but we've taken a
no.
no balloon.
we
Maybe
took the
ETO
old,
balloon is a better test.
It's
Yeah.
I
We
think
took
they're
the
using,
old,
you're
new
using the new balloon or the same 3.5 mm balloon?
So it's
So it's not going.
I think
It seems to be it's going from the back.
better choice is to use the aux balloon. I think this is the aux balloon which is being used.
No. It may be through a strut.
I'm not so sure that it's through the struts because
Well, my dear friends, Alfredo and Anil, thank you very much for a nice case demonstration. I know you are having some problem, but the time is over. So we need to close this session. Thank you very much, the panelists and everybody involved. Thank you very much.
Thank you, Chairperson.
okay, thank you. We will show you later on the case if we can.